Good evening, ladies and gentlemen. At the outset, I would like to thank the Emirates Down Syndrome Association for inviting me to present at the World Down Syndrome Congress in Dubai 2021. My name is Dr. Soman Nair, and I'm specialist ophthalmologist and retina surgeon at Zuleika Hospital, Dubai. Today, I shall be presenting on the management of ophthalmic manifestations of Down syndrome. Down syndrome, as you're all aware, is the most prevalent genetic disorder associated with intellectual disability and is due to the presence of complete or partial triplication of chromosome 21. It is associated with a characteristic physical and cognitive phenotype. It carries a shortened life expectancy and is associated with multisystemic anomalies, including ophthalmic abnormalities. The ocular findings in Down syndrome may be classified as structural or functional anomalies. These include cataracts, nystagmus, strabismus, keratoconus, amblyopia and refractive errors, and lid and orbital anomalies. There are several other ophthalmic manifestations in Down syndrome. However, they occur very rarely and shall not be discussed here. Cataract is a very common ophthalmic manifestation of Down syndrome. Its prevalence ranges from 11 to 47% in various populations, as reported in various studies. It is a significant cause of visual deprivation in Down syndrome. Cataract is a term which is applied to opacification of the lens inside the patient's eye. As you can see in this image, multiple speck-like opacities are noted in the lens of the patient. Majority of the cataracts in Down syndrome are white cataracts and bilateral cataracts. White cataracts indicate delayed treatment in the population because these imply that the cataracts have been present for a long time and are mature or hypermature. The bilaterality of cataracts indicates the higher incidence of the cataract and the high prevalence of the disease in these patients. As can be expected, the major symptoms of cataract in these patients include decreased vision, which can be partial, which can be corrected with refractive corrections, or complete, which require immediate surgery. Patients in milder forms of cataract may also present with significant glare, which affects the visual quality of the patient. Other coexistent problems like keratoconus, myopic maculopathy, and amblyopia cause suboptimal visual gain after cataract surgery. In milder forms of cataract, one can perform refractive correction. That is, you can give refractive corrections or refractive glasses to correct the refractive error secondary to milder forms of cataract. But when the cataract advances to form mature or hypermature forms, one requires to undergo cataract surgery. The definitive treatment for cataract is phacoemulsification with intraocular lens implantation. This surgery is, in this population, performed classically under general anesthesia and involves procedure through keyhole incisions. As you can see in this image, the central phaco probe, which is on the right side of the left image, usually emulsifies the white cataract and breaks it down to smaller pieces, which are sucked by the central pipe to cause complete removal of the cataract and a clear visual axis, as can be seen in the right image. The central capsular bag in this patient is then replaced with an intraocular artificial lens. The improvement in the vision is because of the refractive correction provided by the intraocular lens. Good visual gain is usually obtained in the absence of other ocular comorbidities. Strabismus is squinting of the eyes, that is inward or outward deviation of either or both eyes. Up to 50% of children with Down syndrome report some form of strabismus. Isodeviations or inward deviation of the eye are commonest in this population. The causes are, commonest cause is abnormal vision, which is the sensory part of strabismus. This is because when the patient has abnormal vision, either due to refractive error or amblyopia or cataract or some other visual anomaly, the rays of light can't enter the eye This affects the ability of the brain to fuse the eyes and can cause either outward or inward deviation of the eyes. One can also have motor causes for strabismus, where there is lack of coherence of the muscle movements of the extraocular muscles. The initial management of strabismus or squint comprises of refractive correction. In patients with sensory forms of strabismus, that is where the basic cause of the strabismus is essentially the absence of good vision, one can attempt to correct those by either removing the basic cause of the low vision or by giving refractive corrections. In some patients, there may be coexistent amblyopia, and this coexistent amblyopia also needs to be treated with patching therapy before any form of definitive surgical treatment can be considered. The commonest cause of squint in Down syndrome is actually esotropia. That is where there is inward deviation of either or both eyes. Therefore, the surgical management of esotropia in Down syndrome usually involves recessions. Recession means weakening of the muscles, usually recessions of both the medial rectus muscles, which are responsible for inward deviation of the eye, or in small angle deviations, one can also perform unilateral recession of the medial rectus and resection of the lateral rectus. Nystagmus is abnormal involuntary movements of the eyes. Nystagmus has been observed in up to 1/3 of cases with Down syndrome. Commonest type is rapid horizontal nystagmus. The nystagmus may have manifest, latent, or manifest latent components. Manifest nystagmus means that the nystagmus is always present in the patient's eyes. That is, whether the fixating eye is covered or uncovered, there is always nystagmus. This classically presents with low vision because of abnormal involuntary movements and abnormal image formation on the retina. Latent nystagmus is where there is no nystagmus in the primary state. When the patient is keeping both eyes open, there is no nystagmus. But when the fixating eye is covered, or when the patient loses the ability to fuse the eyes, the nystagmus may manifest. This is called as latent nystagmus. Combination of these two types of nystagmus are called as manifest latent nystagmus. Nystagmus is an important cause of visual deprivation and remains largely undiagnosed in patients with Down syndrome, especially the latent form of nystagmus. Nystagmus with a predominant sensory component owing to uncorrected refractive errors or cataracts or other forms of visual anomalies may be treated by eliminating the underlying cause. If the patient has poor vision due to cataract, for example, causing the abnormal involuntary movements of the eye, once you remove the cataract and once you restore the vision of the patient, you can correct the nystagmus. But nystagmus with a motor component, where the problem lies either in the muscles of the eye or in the parts of the brain controlling the muscles of the eye, are more difficult to treat and may be the cause for persistent visual deprivation. Children with Down syndrome have a higher prevalence of refractive errors. Refractive errors is the ability or the inability of the eye to create a clear image of the object in the patient's retina because of some abnormality in the visual medium. Commonest types of refractive errors in Down syndrome are usually hyperopia and astigmatism. Hyperopia is farsightedness, and as you can see in this image, hyperopia is when the rays of light are focused by the cornea, by the pupil, and by the lens at a segment or at a point behind the retina. Such patients with hyperopia can neither see objects which are close very clearly, nor can they see objects which are at a distance very clearly. Astigmatism is where there is abnormality in either the corneal curvature or the lenticular curvature, and this leads to abnormal formation of image on the retina. Failure of emetropization is a major etiology for the prevalence of refractive errors beyond infancy. What this means is that in normal infants, when they are born, the eyes always have a refractive error. There is always an inherent refractive error. The patients are either hyperopes or myopes. As the patient's eye grows up, there is normalization or emmetropization, which means that patients who have refractive error or children who have refractive error when they are very small usually have normalcy in the refractive status of the eye as they become older. This process of normal emmetropization is lost in Down syndrome. Refractive errors, as can be expected, are corrected using appropriate spectacles and require mandatorily cycloplegic examination, as patients with Down syndrome can have very high accommodation amplitudes. The visual acuity in Down syndrome is significantly lower when compared to age-matched controls. Visual acuity is usually examined in the pediatric Down population using tumbling E blocks, as can be seen on the right side, or Teller's acuity cards. These are both very effective techniques in identifying the visual acuity in patients who are non-verbal. Patients with Down syndrome can have multiple lid anomalies. Upward slanting palpebral fissures, as can be seen in this patient, and large epicanthal folds are extremely common lid malformations in Down syndrome and are responsible for the characteristic facies in Down syndrome patients. Blepharitis, which is the inflammation or infection of the lid margins, is extremely common in Down syndrome. And this has been attributed to the pre-existent lid anomalies in these cases, as well as a disturbed immune function and a disturbed local ocular surface. When you have blepharitis or inflammation of the lid margins, the glands in the lid margins get blockages in the ducts. When these ducts get blocked, they are responsible for multiple lid anomalies, including hordeolum, as you can see in the right image, where there is a blocked duct, which is leading to accumulation of pus inside the gland. And this pus points out, as you can see in the image, as a hordeolum externum or a style. When the hordeolum becomes chronic, the infection becomes chronic, and the active inflammatory component subsides, you can have large masses in the lids, which are called chalazion. These hordeolum and chalazion are responsible for significant visual disability and can be extremely uncomfortable to these patients who sometimes are not able to verbalize or communicate well. The treatment of these lid anomalies in the initial stages remains warm compresses. Warm compresses are used to open up the ducts, the blocked ducts, and ensure that the pent-up secretions can come out. Once you apply the warm compresses and the pent-up secretions can come out of the blocked ducts, you can also perform appropriate topical and systemic antibiotic administration. In patients who don't respond to such conservative medical management, one can also resort to surgical removal of the chalazion or surgical excision of the blocked ducts. Patients with Down syndrome also have significant lacrimal duct anomalies. This is because of the characteristic facies of the patients with Down syndrome and are related to the abnormal facial morphology. The nasolacrimal duct, as you can see in this image, is the duct that connects the eye, the medial part of the eye, with the nose. And this part of the face is responsible for the normal drainage of the tears and other discharge from the eye into the nasal cavity. Lacrimal duct anomalies are responsible for recurrent epiphora. Epiphora means watering of the eyes because of blockage in the nasolacrimal duct, and dacrocystitis. When you have persistent obstruction of the nasolacrimal duct, you can certainly have pent-up secretions in the nasolacrimal duct. And these pent-up secretions are a huge source of nutrition for the normal ocular flora. And this is responsible for infection of the gland, infection of the duct, and ultimately resulting in dacrocystitis, as can be seen in the image on the right side. The initial treatment is again warm compress, which is used to release the pent-up secretions and try and open up the blockages. One can also perform nasolacrimal massage, also known as crickler massage, where sequential massages are applied from the eye to the nose to conservatively open up the ducts and hopefully ensure that the pent-up secretions and the tears can flow through the natural course. In recurrent cases, one may need to advise systemic antibiotic coverage, because in children, such infections can spread very rapidly to form orbital cellulitis and can be responsible for life-threatening sepsis as well. In patients who have recurrent dacryocystitis, one may also need to perform syringing and probing, where you take a syringe and you apply it to the proximal opening, and you inject saline so that the force of the saline opens up the duct and leads to resolution of the ophthalmic, ocular complication. In chronic cases which don't respond to these maneuvers, either medical or syringing and probing, one can also perform surgery, which is called as DCR or dacryocystorhinostomy. Keratoconus is a common presentation in young adults with Down syndrome. Keratoconus is one of the commonest presentations or commonest manifestation of corneal anomalies in Down syndrome. As you can see in the image on the left side, keratoconus is a condition where the cornea, that is the front portion of the eye, becomes thin and has a conical shape. This is because recurrent blepharitis, allergic conjunctivitis, and constant eye rubbing changes the shape of the cornea, makes it thin, and makes it more conical. This is also why we advise that patients who have a tendency to itch the eyes should be handled quite urgently, and the tendency, this constant rubbing tendency or itching tendency of the eye, should be curtailed. Keratoconus is a significant cause of visual deprivation in Down syndrome and is noted in up to 16% of the population. It is again responsible for abnormal images, and these abnormal images that are formed in the retina as a consequence of the abnormal refractive changes in the cornea can be managed in the initial stages by appropriate refractive correction and the use of specialized contact lenses. On the left side of the image, you can see the normal contact lens, which is a smaller contact lens, and the specialized contact lenses which are used in keratoconus, which are larger contact lenses and are also called as corneoscleral contact lenses. In patients who have progressive keratoconus, which does not respond to conservative management, one can also perform corneal collagen cross-linking. Corneal collagen cross-linking is a small surgical procedure by which we cross-link the collagen inside the cornea, make the collagen stronger, and prevent progressive corneal ectasia. In patients who have recurrent hydrops, hydrops is where the cornea becomes so thin that it ruptures, and this rupture can be extremely painful and can lead to significant scars in the cornea, ultimately leading to significant corneal opacities. In such patients, corneal transplantation may be necessary. In the image to the right, you can see the diseased cornea, which has been replaced by cadaveric cornea and has been sutured or stitched to the graft bed. Corneal transplantation in keratoconus has a very high surgical success rate and can be performed in patients with advanced eye disease. In conclusion, it is important to remember that there is a significant correlation between visual disturbances and intellectual impairment in patients with Down syndrome. Difficulty with mobility, sleep problems have been reported for older adults with low vision or blindness. Nowadays, with improved medical care, most cases of Down syndrome are surviving till late adulthood, middle or late adulthood, and their sets of problems or their problems with vision can lead to significant damage to the quality of life of these patients. Being legally blind has a great impact on patients' adaptive behavior skills and cognitive functioning. It is therefore important to be highly sensitive to the possible visual disabilities and correct them at the earliest. In this presentation, I have attempted to sensitize the audience to the commonly seen visual abnormalities in patients with Down syndrome, and to try and make them understand that it is possible to correct most visual anomalies in Down syndrome and ensure that our patients have a good and high standard of living. These are the references for the presentation. Thank you.